Good evening, everybody, and thank you for joining us for our latest webinar from the East Sussex Eye Group. Tonight's webinar is being recorded and will be available to watch on our YouTube channel, the East Sussex Eye Group. There is CET points available tonight for optometrists and dispensing opticians if you're watching it live through the link. The lecture will run for approximately 45 minutes with about 15 minutes of time at the end for questions, and there is a Q&A box at the bottom of your screen. So during the webinar, if you have any questions, please type them into there. And at the end of the lecture, we'll try to get us through as many as possible. So I'd like to welcome tonight's speaker, Mr. Shahram Kashani. He's an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex medical retinal disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior segment laser treatments, as well as high volume cataract surgeries. He has previously been the clinical lead for East Sussex NHS Trust and is now the head of retinal services and uveitis. Tonight, he will present to us a webinar on matters in the retina, differential diagnosis and management. So thank you very much, Mr. Kashani. I'd like to hand over to you now.
Thank you, Ian. Now, let's see, just going to share the screen. Hopefully that should have come up. Okay, good. Right, so thank you for those of you who've joined. Before we start, I was just going to say that if there is any particular talks that you guys would like to hear, if you could please just email, WhatsApp Ian or email him, or me or Cash for that matter, for any particular topics. And then, you know, we can see if there is a common theme and we can get to it. Obviously, some of these are already kind of pre-arranged and decided, but, you know, certainly we want to make sure that we're doing talks that are of interest to you. So if there is anything like that, then please let us know, and we can go ahead with that. But today we're going to talk about just abnormal masses in the retina and workup, investigations, and treatment options. So really how I'm going to divide this talk is discuss tumors of the choroid, tumors of the retina, and tumors of the retinal pigment epithelium. The common things that you probably all see is choroidal nevus, and often there's the kind of panic about when is it nevus, when is it melanoma, and hopefully during this talk you'll get some sort of idea of how to differentiate between them. The hemangiomas, melanocytomas, osteomas, and mets are pretty rare and unusual, so we'll obviously go through them, but you're likely maybe to see a few in your career. Within the retina, retinoblastoma, so we'll spend a little bit of time with that, because that's something that you are kind of that you've been taught about, and red reflex something for us to look at. And then primary intraocular lymphoma is again another important thing that I'll spend a bit of time about, only because it can get mistaken for in patients with chronic uveitis that don't respond to treatment. And then we'll spend a little bit of time on CHIRPE, congenital hypertrophy of retinal pigment epithelium. And that's because you have to know when to worry about a CHIRPE. Certain types of CHIRPEs are associated with lethal medical conditions, and it's an important thing to know when to actually worry about it. Okay. Now, okay. So we are good. Sorry. Go back one. So choroidal nevus, this is probably what a lot of you will see throughout your career. 5 to 10% of Caucasians have choroidal nevus, and it's more unusual in dark-skinned individuals. You're probably born with a choroidal nevus, and it grows during pre-pubertal years, but it's very unusual for a nevus to grow after pre-pubertal years. So if you are seeing a patient with a nevus, and it's not one that's suspicious of malignancy, it's fine to follow it up with, you know, serial pictures every year. These patients will be coming to you for test, etc., on a yearly basis. And so you should picture it in order to see if it's changed. Any growth or change in an adult should make you think that it's going through a malignant change. So it's important to recognize that. And a nevus is what we call a hamartoma, which is basically a non-cancerous tumor, which is made up of abnormal mixtures of normal tissue from the surrounding area. So you've got to kind of think of the nevus as something that you're born with. It probably grows a bit until you reach adult stage, and then it should remain stationary. And because it can induce changes on the retinal pigment epithelium, you can see changes on top of it. So so it's quite normal, in fact, to see drusen on top of a nevus. Sometimes you can see a bit of atrophy. It can even induce a choroidal neovascular membrane, although I've never seen it. And occasionally you can get these other secondary changes in the retinal pigment epithelium, which is sitting above the nevus, called the lipofuscin. And that orange pigment is important. We'll come to that in a minute. So a nevus on its own should be fairly flat, and it may be associated with some drusen on top, but really you shouldn't see lipofuscin or anything else like that. So often it's asymptomatic, so there are no symptoms. Occasionally you might get a secondary choroidal neovascular membrane because there are changes within the RPE, and whichever condition that affects your RPE can cause a choroidal blood vessel go through into the retina, hence the choroidal neovascular membrane. And sometimes the nevus might be symptomatic, not just because of CNVM, but it might be affecting the fovea. And then if you're affecting the RP above the fovea, then you can be symptoms as well. When you look at the nevus, it should generally be around less than 3 millimeters in diameter and less than 1 millimeter thick. Now, the thickness is a bit difficult to distinguish, obviously, because you don't have an ultrasound in practice, but you can generally see if the blood vessels are elevated or if it looks elevated. I think if you can see a clear kink in a blood vessel and it looks elevated, then that should make you think that there might be some elevation there. And the only way to look at that would be to do an ultrasound. With respect to the size, if you imagine that a disc diameter is 1.5 millimeters, so the width or the height should be 2 disc diameters on the side of each other. So if it's bigger than that, again, that should make you concerned. It can be gray in color with kind of soft borders. As I said, you can see drusen on top. So this is a picture of probably a nevus that's roughly around 3 millimeters. This would be a borderline case for me, okay? So you've got some drusen on top, which looks normal. But then you can see here that it's kind of away from the disc, and I'll come to say why that's important in a second. There are times that nevus can look atypical, however. So for example, in this one, it's what we call a halo nevus. So it's surrounded by kind of a pale rim around the central gray area. And sometimes nevus can appear as a lump, but it can be colorless, i.e. no color to it. So that could be amelanotic nevus. And actually, a lot of times with these kind of conditions, you can see it if it's fairly central, you can see it on an OCT. So when you're in an OCT, instead of a flat line, you will suddenly see kind of a big rise in RP almost being pushed out, and that should make you think that there is a mass in the choroid. So when to worry about a nevus? Well, you should worry if a nevus has symptoms. So this can be present as a result of blurred vision. Sometimes you might get a field loss if the mass is elevated, and that's why you should be worried, because you would think that the nevus is becoming a tumor. You can get subretinal fluid and elevation of neurosensory retina, so that can cause metamorphopsia and photopsia and those kind of symptoms. With respect to size, anything, we said more than 3 millimeters in size and 1 millimeter thickness, but so definitely if they're more than 5 millimeters in diameter, then you should definitely worry. But from a referral point of view, more than 3 millimeters in height and 1 millimeter in thickness should make you worried. Presence of orange pigment, that's lipofuscin, should make you concerned. That's very different to drusen. Drusen is kind of, as you know, yellow dots. Lipofuscin is orange pigment within RPE. Interestingly, actually, absence of drusen in nevus should also make you concerned. So normally you expect to see these secondary changes such as drusen. So if they don't have drusen, that should make you suspicious as well. Lesion by the disc. And obviously we've also mentioned that any serous detachment from the lesion. So an atypical nevus is a nevus that is symptomatic, that's got lipofuscin, that's large and thick in diameter and size, that has got subretinal fluid over it, or if it's by the disc. Those things would make me think that it is something that needs to be looked at. With respect to subretinal fluid, again, if the disc is within the OCT level, you can kind of scan over it and see if there is fluid. If it's not, then there isn't much you can do. But if it is, you should try and definitely OCT over it because that will show you subretinal fluid. So what do we do? Well, if it's absolutely typical, so, a small nevus, looks flat, has got all the right features, once it's seen in clinic, we just discharge them back to your good selves. These patients are seen once or every 2 years for a routine eye test, and they can be pictured locally. However, if the patient is, say, a glaucoma patient or got some other medical problem, ophthalmic problem, then we will probably just picture it on a yearly basis to make sure and document that it's not growing. Anything suspicious then will need to be followed up by us indefinitely. So if you've got any nevus that doesn't fit the typical criteria, we follow up, and we follow them up by baseline pictures and ultrasound, and then we picture them every year, repeat the ultrasound to make sure that there's been no growth. Remember, we said anything more than 1 millimeter thickness is suspicious, but actually the measurement error within ultrasound can be 0.5 millimeters. So sometimes, you'll do a scan and then it will say, may or may not have grown, and then we might have to get them sooner to make sure that that hasn't happened. So here you've got a picture of obviously a very mushroom-shaped mass within the eye, and that is clearly not a nevus, but it's more of a melanoma. So a choroidal melanoma is a tumor that can metastasize, and definitely something you would not want to miss. So if you look in the picture up here, you can see that there is a very large lesion by the disc. This patient is almost certainly symptomatic. Okay, it's away from the fovea, but where it is, you would get field loss. It looks thickened because you can see the blood vessels being arched over it. And it clearly doesn't look like a flat nevus. So this would be the kind of condition you see as melanoma. We see about 5 cases per million. In my career, I've probably seen 3 or 4 patients with it. It's rare in children, but when you do see it, it's quite obvious. And there's no gender predilection within patients with nevus. It's, again, like nevus, commoner in Caucasians, that dark-skinned individuals. There are certain conditions that can make you more predisposed to choroidal melanoma, and these include patients with neurofibromatosis or patients with these other conditions that I've mentioned here, atypical cutaneous nevi, those with melanocytoma. We'll come to that in a minute. So if you look at the eye, this is called, I think, nevus of OTA, OTA, and you've got some pigmentary changes over the sclera over here in this patient. So these conditions can increase the risk of melanoma. It's still a pretty rare condition. And the way they can present with a melanoma, it just pretty much depends how it is. But the reason we worry about a melanoma, and that's where you need to differentiate a small nevus from a small melanoma, is that it can spread. So it can spread into the eye by breaking through RPE and into subretinal space. It can invade sclera and kind of cause local growth. It can go through the optic nerve, and it can metastasize through the blood vessels. And often patients with choroidal nevus, if they have metastasized, will have mets in the liver. So we used to organize ultrasound of the liver and do a liver function test for patients with melanoma to screen for mets. But you can also get lesions in bone, skin, and lung. And it's generally quite bad news if they've met, although recently there's been immunotherapy for which management of melanoma metastasized has been better. So I wouldn't want to go too much into that, but although that's good news, you obviously don't want to get to that point. And then there's certain other features that would make you more worried about a melanoma. For example, what the cytogenetic studies show in that where it is, size, how much is spread, and adverse histological features, which again go with any kind of tumor. But management of choroidal melanoma really depends on the size of it and where it is. I'll come back to this. So you could, in fact, not treat, sorry, let me just close the door. You could, in fact, not treat a melanoma. So if you've got it in somebody who's really old and the patient is frail and they're ill and they're likely to outlive the condition, then you don't have to treat it. In lesions that are smaller, I remember from my days at Moorfields, we used to do brachytherapy. So, apply local radiotherapy to patients, and patients used to come and we'd have to remove the plaque after a certain time. Transpupillary thermotherapy is another way where through the pupil you use treatment to kind of manage the melanoma. So these would be more for kind of lesions that are amenable to that kind of therapy, and radiotherapy and other things that we mentioned. But surgery is obviously a big thing here. And sometimes you're looking at enucleation or even exentration if there is involvement of the orbit. So apart from all that, obviously patients' wishes and the fellow eye is also important. So if they've got no vision in the other eye, then you would want to do anything to avoid exentration or enucleation. But the way patients will present with melanoma, so again, you've got a nice picture here of this very large mass in the back of the eye surrounding the optic nerve, is they can be asymptomatic if they're small and in the corner, not causing problems, but they can cause, if they're big, visual field loss, they can cause metamorphopsia, they can cause pain if the ciliary body is involved, and you can get neovascular glaucoma. And when you look at the back of the eye, you're often looking for this raised dome-shaped lesion, which might be associated with a localized retinal detachment on top of it. It's common to see the orange pigmentation in form of lipofuscin. Sometimes if you see the bottom picture here, you can see this thing called the sentinel vessel. And that normally is a very prominent vessel, which means that your ciliary body has been involved. If the melanoma involves the optic nerve, you can get central retinal vein occlusion, and that's from just a strangulation of the optic nerve. And other things, as I mentioned, rubeosis, uveitis, or a diffuse tumor can be other presentations. But normally, when you look at the back of the eye, you have a good idea that this patient, in fact, doesn't have a nevus and has a melanoma. The difficulty is differentiate a large nevus from a small melanoma. That's where it gets difficult. We've been through this already. Okay, so that's kind of the talk. The take-home message really from here is that anything that's not typical of a nevus should be referred on. So you shouldn't have symptoms, you shouldn't have documented growth, it shouldn't be more than 3 millimeters in size or 1 millimeter thick. It shouldn't have lipofuscin on it. It shouldn't be near a disc, and there should be no subretinal fluid. So that's kind of, anything beyond that is not normal. Otherwise, you can just watch it once a year, make sure you picture it, and you can compare the pictures, and that should be adequate. There should be no growth in adults in a choroidal nevus. Next one, so now we get to rarities before we come to some commoner things. So choroidal haemangioma. So haemangioma is essentially presents as a dome-shaped pinkish mass in the back of the eye. I have seen a few, and you see them by just essentially looking at a macular scan and seeing that sometimes it can be a bit deceiving because you don't really appreciate the dome, but again, you do a macular scan, you can see it. It's a hamartoma again, which is a bunch of non-cancerous cells, and it's got a mixture of normal and abnormal tissue, and and you see it as a growth. So it can be congenital, but it can remain. It is congenital, but it can remain dormant until adulthood. And if you see where it is in the center, you can get blurring of vision, you can get visual field loss. Because it can cause significant elevation of the retina, it can simulate a CSR, so you can get hypermetropic shift, and that can be kind of seen as well. Or it might be asymptomatic if they're small enough. So it's a discrete round mass, it's pink in color. Often it's in the posterior pole, in the macula, and it can be associated with intraretinal or subretinal fluid as well as exudation. So if those are present, we definitely, well, if you are worried about a hemangioma, we definitely need to see, and they need treatment. So here's another kind of picture of it. So you can see what I was telling you here in the OCT. You can see a definite smooth elevation. This looks very different to a pigment epithelial detachment, which is often a lot smaller in base than that. You know, clearly this is kind of something in the choroid pushing everything forward. You can see subretinal fluid underneath, and you can see that mass that I mentioned to you. So this patient will need treatment because they're very symptomatic, and often treatment, if they've got abnormal choroidal neovascular membrane, is in form of PDT laser treatment, or you can do transpupillary thermotherapy for these patients as well, or radiotherapy. Picture here shows a patient who's had radiotherapy over time, and you can see the hemangioma has disappeared because that smooth dome has gone smaller and smaller as the hemangioma is treated. Hemangiomas are, as I said, congenital and normally kind of present on their own, but if it's a diffuse hemangioma, and diffuse hemangioma is difficult to see because it involves the whole of the choroid, it's associated with Stage-Weber syndrome. Right. This hopefully most of you won't miss. Melanocytoma is a condition which involves a pigmented nevus, which is often surrounding the disc. Unlike a normal nevus or melanoma, it's more common in dark-skinned individuals, and it may turn into a melanoma. So this is something that we would definitely follow up in the hospital as well. Because of where it is on the disc, it can cause a visual field defect, or it can cause blockage of a central retinal vein or artery, mainly vein. And we don't really need to do much about a melanocytoma unless it becomes malignant. So it's generally quite obvious to see just from the appearance. You can clearly see a very abnormal mass that's pigmented surrounding the disc. Again, rare. Osteoma is similar to a hemangioma in its outlook, except that unlike a hemangioma, it tends to present in the second or the third decade of life. It's slowly growing, and in 25%, it can be present in both eyes. And essentially, it's mature bone within the choroid with evidence. So, and you can get RP atrophy on top. Often the way you differentiate, hopefully, is with the color, because osteoma is not pink, but sometimes there are various ultrasound features when you're looking at choroidal melanomas, hemangiomas, and osteomas. They look at reflectivity and vascular flow and things like that when they do an ultrasound. So ultrasound is a very important investigation when you're trying to differentiate amongst these things. And normally, you don't actually need any treatment for an osteoma, but you might want to use laser treatment or systemic steroids if they are starting to cause problems with symptoms. Choroidal Mets are unusual. I've definitely seen a few in patients. Often you're unlikely to see them in the community because the patient would be too frail and ill to present. I have unfortunately seen a few of these patients who have, presented with just abnormal visual field defects or, blurring of vision. And when they come, they'll tell you that a few years ago they had breast cancer or kidney cancer, and they've been signed off. And then you look at the back of the eye, and unfortunately they've got kind of retina riddled with these tumors, which is really heart-sinking. But often when you do see them, the patient has already been on chemotherapy, they're on palliative care, and it's not too difficult to know what the diagnosis is. Management often, to be honest, depending on the stage of the tumor, is again palliative. I would write to the oncologist and tell them what I found. They might try them on different chemotherapy depending on what they're being treated for. There are some very good agents now, biologics and immunotherapy, that targets things. And again, that's way over my kind of knowledge level, but we know that oncologists are becoming better and better in treating tumors. But often when they present like this with choroidal mets, it's not a good outlook. I don't often tend to use ultrasound or anything else like that, and we probably wouldn't organize CT MRI. We would probably just refer them on to the oncologist. But there are times where actually the patient hasn't got any obvious thing in the history, and you might want to biopsy it to see where the original tumor is. So most patients are observation. Occasionally you might do radiotherapy. I don't think enucleation is done often for this. And again, so we've gone through that. Okay, fine. So the main, I think, thing with the choroidal tumors, therefore, is mainly knowing nevus, knowing when you worry about it becoming a melanoma. The haemangioma and osteomas are rare. You might see one or two in your career, but essentially, look out for it in your CT scans, because that's when you're likely to see it if they're in the posterior pole, especially with the haemangioma and the osteomas. And you're looking at it and you're thinking, this looks far too wide-based or weird to be just a pigment epithelial detachment. And hopefully that should alert you to think that actually this is a mass in the choroid. Retinoblastoma, so this is the condition that often gets referred to us in panic because there is absence of red reflex. It's the most common primary intraocular malignancy of childhood, and 3% of childhood cancers are retinoblastoma. Normally it occurs in 1 in 18 to 1 in 20,000 live births, and in about a third of patients it can be bilateral, but very much asymmetric, and good survival rates. It all depends on what kind of retinoblastoma is, and this is a very simplistic division of retinoblastoma. So 40% of the patients have what we call germline or hereditable retinoblastoma. So all the cells have got one abnormal gene, and all you need is a second hit, as they call it, of mutation for the retinoblastoma to occur. So 40% of the retinoblastoma belong to that. And in these patients, because the germline cells have the defective gene, often it's bilateral, and often you can get other tumors, such as osteosarcoma or soft tissue sarcomas, which is not great news, and brain tumors. So patients with this type of retinoblastoma will have other issues going on with them. 60% though have somatic mutation, which is basically a chance finding. So there's no family history, and they don't then have other soft tissue tumors or brain tumors. Presentation can be different. And again, the most common referral thing would be absence of red reflex, but you could get leukocoria, which is a white reflex. Patients can present with a squint. If the tumor is missed and it starts invading cellular body and the angle, you can get secondary glaucoma. So you can present with uveitis, as you can see here. You can get this hypopyon, as you can see, in a white eye. So hypopyon in a white eye and nodules should definitely worry you. So these are kind of presence of tumor cells. They can present as orbital cellulitis, so inflammation around the eye and the lids. And when it's really bad, then invasion of the orbit. So you can get orbital inflammation or orbital invasion. And so it's an intraretinal tumor, so it can grow within the retina, but other ways that it can grow is that it can grow out into the vitreous with what you can see as vitreous seeding, or it can grow into the sclera. And hopefully, if any of you see any of this, would know that something is definitely wrong. But thankfully, in a lot of patients, it might be something different, not retinoblastoma. So it could be Coates disease, which is unilateral, mainly occurs in boys. Retinopathy of prematurity can present in a similar fashion. Bilateral toxocariasis can present as a solitary white mass, which can be mistaken for retinoblastoma. And in fact, the child might have uveitis or endogenous endophthalmitis. So there are other conditions that can look like it, but always be aware of retinoblastoma. And remember presentation, which could be, uveitis, orbital inflammation, orbital invasion, but more commonly an unexplained squint or a white reflex. And depending on the size of the tumor, and its location. There are various treatments, but essentially small tumors are treated with cryotherapy or chemotherapy or transpupillary thermotherapy. Medium tumors, brachytherapy or chemotherapy, and larger tumors, then you're looking at enucleation, which can be quite difficult for a child, but you have to think about spread and other consequences. Astrocytoma is rare. I've seen a couple when I was at Moorfields, and again, probably because it's a tertiary center. It occurs in 50% of patients with tuberous sclerosis, which is a condition with specific clinical features. But it looks kind of like a mulberry whitish lesion, and you can kind of see that in the retina. May or may not see it. It's very rare, so you're unlikely to see. But hopefully, if you see that, something is very wrong. Capillary hemangioma, I've lasered a few of these and they look very impressive. You can see in this picture just a very large vasoproliferative tumor there. And it is associated with a condition called von Hippel-Lindau syndrome, where you can get brain tumors and kidney tumors. So these kind of when you see this in the back of the eye, it makes you think about these other conditions. And you basically try and laser the tumor so you stop the this kind of malformation that's present in the back of the eye. So again, quite rare, but these certainly the capillary hemangioma can present with a vitreous hemorrhage or kind of some sort of vascular bleed. So treatment for that is argon, cryotherapy, brachytherapy, or VR surgery. So again, pretty unusual stuff. Cavernous hemangioma, autosomal dominant, rare, looks like a bunch of grapes. And you don't really need to do much with these, but clearly when you look at that, you think something is very wrong. You probably need to treat it if there's vitreous hemorrhage, but nothing else. And then the picture here, you can just see this like worm-like tumor in the back of the eye. That's called racemose hemangioma, which occurs as a result of arteriovenous malformation, and it's often unilateral and congenital. So just some pretty pictures really of things that you might see in the back of the eye. Just remember, if it's yellow by, like that, then it's an astrocytoma. If you see very enlarged and engorged blood vessels like that, you would refer this on anyway. But these are not something you see in diabetic eye disease or central retinal vein occlusion. These are, when you see something like that, there is something very wrong in the back of the eye. Now, I want to spend a bit of time on this because this is probably a bit more common than you think. So this would be your elderly patient that would present with persistent floaters in both eyes. You must be able to really know how to look for vitritis. So when you're looking for vitritis, you're looking through the microscope. The light and the viewing and the microscope should be in one line. And then you're kind of using that kind of transillumination reflex. And when the eye looks up and down, you can just see lots and lots of dots in the vitreous. You're looking at the red reflex and looking at dots within that. Try that in few normal patients where you see nothing. Remember, both the viewing microscope and the light have to be in one line. You shouldn't be dividing them. And persistent bilateral vitritis should make you think about lymphoma. Now, these patients are often quite ill because primary intraocular lymphoma is a CNS disease. So it starts off within the brain or within the spinal cord. Sometimes it might start off in the eye. And most people kind of see it as a bit of vitritis. Blood results don't come back as anything in particular because it's within CNS, so your full blood count might be normal. And then they're treated with steroids. And initially you might get a response, but then it doesn't. And the patient kind of gets worse. When you start getting these lesions in the retina, it becomes quite easy because actually very few things can do this. In fact, when you get this white mass, subretinal mass, which forms a circle in the back of the eye, that's pathognomonic of primary intraocular lymphoma. That means nothing else can do that. And treatment is chemotherapy. I've seen one in my time since I've been in East Sussex NHS Trust, and he used to have methotrexate injected intravitreally once every week. He was very ill and he really hated it. But obviously you need to do systemic treatment, and it unfortunately carries a very poor prognosis. These are quite aggressive tumors, unlike other lymphomas which don't tend to be as aggressive as this. Okay, so remember the beginning of the talk, we talked about nevus and what to look out for, etc. Now I'm going to talk about Choroidal. Now, a lot of you would have seen this picture here. So this kind of well circumscribed, very dark lesion known as congenital hypertrophy of retinal pigment epithelium. Ian will be pleased to know that I got the name right this time. And when it's like that, then it's fine because it's benign lesion. You don't need to do anything. So you need to know when it's typical and when it's atypical, because atypical Choroidal is associated with a condition called FAP, FAP, familial adenosis polypi, and FAP can cause loads of adenomas in the gut, which will become tumors, or you can die from sudden hemorrhagic through the bowel. So you need to know the difference between the two. So when it's like this, you don't need to worry. So it's well circumscribed, dark lesion, you can get white spots inside, then that's fine, or the atrophic areas can be a bit bigger and they can coalesce and kind of appear bigger. Or you might see bear track. I'm sure some of you would have seen that. So these are just as if like you see how bears walk in the snow, okay? So bear track, which is usually unilateral with it in one eye. Again, Choroidal, when it's like this, or when you've got these white lesions on it, or when it's like a bear track, it is pretty much on one side. It's not bilateral, it's unilateral, remember that. And sometimes it can be like this, where it's essentially very depigmented lesion. So again, unilateral depigmented lesion, that's fine, okay? So that's typical. Atypical Choroidal, so this is the ones you have to worry about because that's associated with familial adenosis polypi, which can cause the tumors, or Gardner syndrome, is bilateral and it's multiple. So when it's in both eyes, multiple, that should make you concerned. And then they look at how it is. It's not circular. They're like spindle shaped. Yeah, they're like oval spindle shape, and they've got this hypopigmented rim on one side. So when you've got lesions that are spindle shaped, bilateral, and if they've got a hypopigmented thing on one side, then that definitely needs prompt referral, because we then need to ask the gastroenterologist to check them out for this condition. Now, FAP, there's like a center, there was a center at Northwick Park, which would, because it's a genetic condition. I'm pretty sure they've still got St. Mark's doing it, but we might need to check that. So if you've got lesions like that, then that definitely needs a review and we need to have a look, okay? So remember the difference. Unilateral, if it looks like dark circle, if it looks depigmented inside, if it looks like bear track or completely depigmented, you're okay. If it bilateral looks oval shaped with a hypopigmented margin, you're not. You need to refer that on. And then finally, combined hamartoma of retina and RPE. So this is again another rare condition, which is unilateral, commoner in males and females. They usually have been diagnosed with neurofibromatosis or tuberous sclerosis, which would have been picked up early on, and you can see this in the back of the eye, but it can present in childhood with squint. Now, before we finish off, I just want to show you what we need to do when we refer patients to morphers with possibility of a tumor. So now we have to kind of fill out this form, but essentially this is kind of, you've got this thing called a moles scoring system, because they're probably getting so many referrals that you can no longer just refer a patient on. So you get a score. So the first question on this, and I suppose you can kind of ask this through your head. This is only for melanomas, by the way, okay? If you're worried about a nevus being a melanoma. Is it mushroom shaped? So definitely no. Or you could just see that it's kind of breaking through the RPE, or you're not sure, you give it a 1, or definite kind of mushroom shape pushing through, then that's a 2. And that already makes you a high risk nevus. So if you've scored that, you're there. If it's a 1 because you're not sure, then that's maybe low risk nevus. Okay. Presence of lipofuscin. It's either, you know, a bit of dusting, you're not sure, or confluent orange clumps, not drusen, orange clumps. If it's present, then look, it goes to probable melanoma. All right. Size. So we said less than 3 disc diameters or less than 1 millimeter. So here you've got, so let's assume that there is no orange pigment. Let's assume that it doesn't look like mushroom. So if you've got 3 to 4 disc diameters in size and thickness is 1 and 2, again, that gives it a low risk. But if it's anything more than 4 disc diameters or thickness of more than 2 millimeters, then that becomes high risk. So with thickness, I do appreciate that you don't have an ultrasound. We'd send them to our radiology department to tell us. But again, you look for clinical signs. So just see what the blood vessels like. Does it look elevated? Then I think if you're worried, then you need to refer. Enlargement, any documented growth. So you would have taken serial pictures and you could see, looking at the markers, you know, where they are with next to blood vessels, etc., whether there's been growth or not. And if it's certain, then, you know, the index gets a high score, and presence of subretinal fluid. So subretinal fluid with OCT only gets you 1 score, and if it's significant, gets you 2. So, and we use that along with, as you can see here, they want images like OCT, autofluorescence ultrasound, which we have at hand, and we can send that to them, and they can tell us, you know, what it is. And, you know, sometimes they have a look and they go, yeah, it's not, and then we'll have to monitor it. So we'll have to follow the same process. I think I've done quite well, actually, because that's 44 minutes. I'm going to stop sharing and allow my friend Ian to come and tell me what he thinks.
Hi, Shah. No, that was that was really good. Second time I've seen that talk, and I enjoyed it just as much the second time as the first time.
You're a time, Ian. I'll pay you later.
So we have got a few questions, Shah. I think you may have brushed over these, but if you could just, you know, answer them again. Is a nevus close to the disc more suspicious than one elsewhere?
Yes. So if you've got a nevus that's close to the disc, then that does increase the risk.
Good. And how can we...
Sorry, so what I would do with that is, if it's close to the disc, look at the other things. If it's close to the disc, you should be able to OCT it. Do the OCT yourself rather than asking your technician. Move the kind of 6 millimeter thing on the OCT. Check if there's any subretinal fluid. You can also see on the OCT whether it's elevated or not, okay? So if it looks flat as a pancake and it's just by the disc and nothing else, then you probably don't need to worry. But if there are, you know, if there's any subretinal fluid over it, that would definitely make me worried. If, as you could see in that mole's questionnaire, being by the disc wasn't one of the things that they would ask for. So we know what kind of nevus to be worried about. You know, we've said, you know, by the disc, symptoms, lipofuscin, presence of fluid. You know, if we were to send every single nevus by the disc to, you know, for secondary commenting, that might take, you know, quite a lot out. So what I would do is look for lipofuscin. If there's lipofuscin, I would definitely worry. OCT it. If you've got fluid over it, I would definitely worry. If it looks flat and it's by the disc and it's small, less than 3 millimeters in size, then, you know, you could just watch it.
Lovely, thank you. How can we measure the size of a nevus? 3 millimeters, how many disc diopters?
So diameters, yeah. So I think if you can imagine the diameter of the optic disc to be about 1.5 millimeters. So 3 millimeters would be 2 disc diameters. But again, as I mentioned in that Morse questionnaire, they've actually gone higher to say 3 disc diameters. But I would say, but that's probably going around the kind of 5 millimeter mark, isn't it? So I'd say anything more than 2 disc diameter in size should make you think this is a large nevus. I need to get it checked out.
Yeah, perfect. I'm not quite sure about this one. Is the wide field imagery from the Zeiss Claris with a question mark? I didn't see when that question came up in your talk, but I'm not sure.
I mean, yeah, I mean, wide field imaging from Zeiss Claris can be very useful to pick up pictures. So the other, there are various machines around to get wide field images. But again, you're just applying the same principle as, what you normally do. I mean, you should be able to pick out most of these things with a good dilated fundus picture, fundus imaging, and clinical examination. But I would imagine most people would have cameras in their practice to be able to pick out most of the things. But yeah, if the nevus is very peripheral and you can't picture it and you're worried about it because it's got features that you're worried about, then you should refer it in and then we can reassure you.
Perfect. That's the questions, but there was one statement saying absolutely fantastic talk.
Oh, is that me again writing for myself? So I think, look, guys, just what you really want to be aware of is not missing a small melanoma. I think that's what we all kind of panic about. So I think, if unsure, you have to refer. I mean, there's no doubt about it. And just remember the things that would make you panic. I think if you're going to remember two things from today's lecture is when to worry about a nevus and when to worry about a chirpy. So a nevus, you worry about if there is symptoms. They're by the disc, you've got lipofuscin skin, they're large, they look thick, there's fluid. Anything but or they have grown. All those things should make you think, right, this doesn't look like a typical nevus. But if you've got a patient that you're following in your practice and they're coming yearly for pictures, just picture it and have a look and see if there's, it's very unlikely for a nevus to turn into a tumor and not grow in size. So you would normally expect some sort of growth. Or if there's been, suddenly you start seeing these orange pigments on top of it, then, so often all these features will occur together, but you might just get one or two and not the other. Getting an OCT over a nevus can be invaluable because it can tell you about presence of subretinal fluid, and that's one of the markers we look at. And I think, unless it's kind of small and flat, which most of them are, then that should make you worried, and then we'll follow it up. With a chirpy, it's quite simple, really. If you see it in both eyes, if they look spindle-shaped with that hypopigmented edge, then you must send it in. And that's because it's associated with this condition, which will definitely cause cancer. Now, a lot of these patients would already have been picked up because through genetic screening, the family would have been identified and they would have been identified. But sometimes, the parents or the father or something might have died early and nobody diagnosed it, and the off-screen might come and you might pick it up. So you might just save that person's life. But if you guys want, Ian, is there any way of, well, actually, this talk will be on the
YouTube channel. Yeah.
Just look at the moles questionnaire. That will often help you to know when to refer. Then, if any of you want the actual PDF, if you let Ian know, I can maybe pass it on to him and he can pass it on to you. And that's a kind of like an interactive form where you can score it and then know. But essentially, any score of more than 2 within those 5 questions added together would warrant a referral.
Good. We've just got a couple more questions coming, if that's okay, Shah.
Yeah.
An enlarged conjunctival scleral vessel that looks like a sentinel vessel in a normal looking eye. Do we need to worry?
I think if you're worried about a unilateral corkscrew or just a very large vessel on one side, we would need to see what that is. So what I would do actually in that kind of setting, you dilate and have a look. So sentinel vessel in this context means invasion of ciliary body with a choroidal melanoma. But as you know, you can also get you can get these screw-like blood vessels as a result of keratoconus fistulas and things like that. So if it's unilateral, then that would make me worried. Or if they look very prominent in both eyes, especially if the pressure is high, then we would want to know. But yes, I would.
What size is considered small in terms of disc diameter for melanomas?
Did you ask that, Ian?
I didn't.
You just wanted to tease me, didn't you? Let me have a look. I think we said basically a small melanoma would be around 3 to 5 millimeters, won't it? So if it's anything less than 3 millimeters is unlikely to be a melanoma, unless you've got other features such as lipofuscin or fluid or something suggesting. But generally, small melanomas would be between 3 and 5 millimeters. And those ones could be treated locally with brachytherapy and TTT, transpupillary thermotherapy, and it would avoid you having to do an enucleation.
Perfect. And somebody's put yes, please to the form. So I'll speak with you about that.
Yeah, I'll email it. Perhaps what we could do is put it on the group. I don't know if you could put a PDF on the WhatsApp group and then they can
have a look.
Yeah.
I'd like to thank Mr. Kashani for that talk today. That was an excellent talk. And thank you all for watching. As mentioned, I will be making a YouTube video of this webinar, and it will be up on our YouTube channel, the East Sussex Eye Group channel, hopefully this weekend. And I will aim to enter the CET details for points for everyone who's attended tonight, again within the next couple of days. So you should get an email about that. But thank you again for your support.
Yeah, can I also say before we go, the other thing to mention is when you're doing OCTs, because once you've done an OCT, it's there for everybody to see. If you see a very smooth, large thing in the middle, it's not a PED. So if you've got, and we've had a few of those that have gone missing, so that does need to be sent for an ultrasound to make sure we are not missing a choroidal hemangioma or an osteoma. So that was my other take-home message. And the next talk, are you doing the next talk, Ian?
The next talk is possibly me doing the next talk. I'll have to start writing the next talk, but I will advertise the next talk on the WhatsApp group.
So very non-committal, Ian, but we'll bully you into it.
I'll try and plan it for when there's something really good on TV for you all to watch instead. But I will hopefully on low vision the next talk. But yeah, I'll start writing that now and I'll advertise it fairly soon. But thank you very much, Mr. Kashani.
That's Ian. Thank you.
Thank you very much for everyone for watching.
Thank you.
Stay safe and keep supporting the group. Thank you very much. Bye for now.